Scoliosis is most commonly associated with adolescence, but its story doesn't end in youth. For many women, the spinal curve that began or stabilized in their teenage years can quietly, and sometimes dramatically, change decades later. One of the most under-recognized phases of scoliosis progression occurs during perimenopause, the transitional years leading up to menopause, typically beginning in the mid to late 40s. During this time, the body undergoes major hormonal shifts that affect not only reproductive health but also muscle tone, joint stability, and bone density. These changes, especially the altered balance between estrogen and progesterone, combined with age-related bone demineralization, create a perfect storm that can reignite or accelerate scoliosis curve progression in adult women. Hormonal fluctuations, estrogen, progesterone, and spinal instability. The hallmark of perimenopause is hormonal imbalance, particularly involving two key hormones, estrogen and progesterone. These hormones work in harmony throughout a woman's reproductive years to regulate menstrual cycles, support bone health, and maintain the balance of muscle and connective tissue. As women enter perimenopause, this balance begins to shift. Progesterone is usually the first hormone to decline. Lower levels of progesterone can result in increased muscular tension, poor sleep quality, and mood swings. But on a structural level, it also plays a role in regulating GABA, gamma-aminobutyric acid, a calming neurotransmitter in the brain that helps relax muscles and reduce neuromuscular asymmetries. Without enough progesterone, GABA function may be reduced, leading to tighter, unbalanced muscle tone, often more pronounced on one side of the spine than the other. This subtle shift in muscle dynamics can contribute to a renewed pull on the spinal curve, especially in women who already have underlying scoliosis. As progesterone drops, estrogen levels become increasingly erratic, sometimes spiking, other times falling sharply. Eventually, estrogen also declines as women reach menopause. Estrogen is essential for maintaining bone strength, collagen production, and ligament elasticity. It helps regulate the activity of osteoblasts and osteoclasts, the cells responsible for building and breaking down bone. When estrogen becomes unstable or deficient, the rate of bone breakdown outpaces bone building, leading to weaker bones, looser ligaments, and less spinal support. In scoliosis patients, these hormonal changes can lead to a resumption of curve progression, even in women who believed their condition had long since stabilized. The combination of stiffer muscles, due to low progesterone, and weaker structural support, due to declining estrogen, creates an environment where gravity, posture, and daily physical stressors can once again push the spine into greater curvature. Bone demineralization, the silent threat. One of the most concerning physical changes during perimenopause is the loss of bone mineral density, BMD, a process called osteopenia in its early stages and osteoporosis when it becomes more severe. Estrogen is a critical hormone for bone preservation, and as levels fall, bones begin to lose their mineral content at a faster rate. This loss is particularly rapid in the first 5 years after menopause, during which women can lose up to 20% of their bone density. For women with scoliosis, this poses a significant risk. A healthy spine is designed to bear the body's weight evenly and withstand movement. But when bones are weaker, more porous, and less resilient, the spine becomes more vulnerable to collapse, compression, or deformation. Even a minor imbalance in posture or muscle tone can result in measurable changes in spinal alignment when bone strength is compromised. Additionally, scoliosis itself may increase the risk of earlier or more severe bone loss. Research has shown that women with scoliosis often have lower baseline BMD compared to women without scoliosis, even before reaching menopause. This means that when perimenopausal bone loss begins, women with scoliosis may be starting from a weakened foundation, making them more susceptible to accelerated curve progression and spinal complications such as vertebral wedging or compression fractures. Postural changes and functional decline. Lifestyle factors that influence progression. Perimenopause also brings changes to a woman's lifestyle, diet, and physical activity, all of which can influence scoliosis outcomes. Fatigue, sleep disturbances, and increased stress are common during this life stage and may cause women to reduce their physical activity levels. A sedentary lifestyle contributes to muscle weakening, joint stiffness, and weight gain, all of which can place added stress on an already compromised spine. Nutrition often changes as well. Appetite, digestion, and dietary habits may shift, sometimes resulting in lower intake of calcium, magnesium, protein, and vitamin D, all essential for bone and muscle health. Without adequate nutrient support, the body is less capable of maintaining strong bones and resisting spinal deterioration. Stress, both emotional and physical, also affects scoliosis progression. Chronic stress raises levels of cortisol, a hormone that, when elevated for long periods, can increase bone loss, weaken immune function, and reduce the ability of tissues to repair. For perimenopausal women, high stress levels may indirectly contribute to spinal changes by weakening both the structural and biochemical systems that keep the spine stable. Preventing or slowing curve progression. The good news is that scoliosis progression during perimenopause is not inevitable. Women can take proactive steps to monitor their spinal health and reduce the risk of worsening curvature. Bone density scans, DEXA, hormone panels, and scoliosis X-rays can offer early insight into physical changes and help guide treatment. Strategies such as weight-bearing exercise, resistance training, hormone balancing, either naturally or through bioidentical hormone therapy, posture training, and nutritional supplementation can make a significant difference in preventing decline. Specialized scoliosis-focused care, such as targeted physical therapy, spinal stability exercises, and core muscle retraining, can help women regain control over their spinal health. These proactive measures are especially important in women with a history of adolescent scoliosis or a family history of osteoporosis. Perimenopause is a critical transition point in a woman's life, and it can be a turning point in the scoliosis journey as well. The shifting balance between estrogen and progesterone, combined with bone demineralization and physical aging, can lead to renewed or accelerated spinal curve progression. But with awareness, personalized care, and early intervention, women can reduce their risk and maintain a healthy, active lifestyle through midlife and beyond. Scoliosis may be lifelong, but with the right strategies, its effects don't have to worsen with age.